So let me transition now into thinking a little bit about what is myeloma? I've already talked a bit about it. It's got a precondition. I just wanted to lay the facts out there to begin with so that people recognize the impact of race in this disease. But now let's get back to the basics. Now, maybe you're a myeloma patient here today and you've had myeloma for many years and you've come to these workshops and you've learned from Kelly and from so many of the others at the IMF that try and teach us about myeloma. Or maybe you're here today and you've really never heard much about this at all. We're going to try to give both of those groups information today. So we're going to provide some very basic things, but also some advanced things. As I like to say, it's like a tree that has fruit way up and fruit way down, and we want to provide benefit to everybody who is here today. So let me go back to the basics of blood. Now, I'm a hematologist, so this kind of stuff gets me all excited. You know, we're kind of geeks in hematology. We like looking at blood under the microscope. I know it's a little bit gross, but let me remind you what blood is. Blood is actually an organ. I know when you think of your heart as an organ, or your liver, or your lungs, or your kidneys, but actually the blood that's circulating through your body right now is an organ, and it's made up of two bits. It's made up of the liquid bit and the solid bit. The liquid bit we call plasma, and the solid bit we call cells, or little circular things that circulate around. And those three kinds of cells that circulate in your blood, I sometimes joke to remember them that they're like wine: red, white, and rosé. So some of them are red, some of them are white. They're not really rosé, they're what we call platelets. And red cells are like little red trucks. They just circulate around and they carry oxygen. They come to your lungs, you breathe in oxygen, they pick up that oxygen, they go deliver them to the tissues, and then come back to your lungs. I know I'm offending every hematologist in the world right now, but that's basically all the red cells do. They pick up, drop off, pick up, drop off. White cells, which we're going to talk more about today, are like soldiers in the army. They're there to protect you and to defend you. So they form an important part of your immune system. And then platelets are these little cells that circulate in your blood, and they help you with clot. If I were to cut my hand, then my platelets get there first. They're kind of like the ambulance. They get there first and they patch up the problem, and then the rest of your body can try and heal that area. These three cells, the red cells, the white cells, and the platelets, are made in the factory of your blood, which is what we call the bone marrow. So we're going to show you that myeloma is a cancer of cells in the bone marrow, is the factory. So when we do a blood test, we can kind of see what's going on in your body. But if we really want to know what's going on in the factory, we've got to go into the factory. And that bone marrow is this space within your bones, mostly within your pelvis and some a little bit here in your chest, but mostly within your pelvis, where your big bones are, and your hip is where you make your blood. So what is cancer then? Well, cancer typically is what we call uncontrolled growth. It's just easier to think about when you think a piece of breast tissue or lung tissue or colon tissue. And so we think of it as just these cells growing out of control. Well, this can happen with blood cancers too. It's just a little bit harder to conceive because it's not just a clump of cells in one place. It's a group of cells that may be moving around. And so your body has this great balance of making sure that cells grow correctly, because we want to be able to grow. We want our hair to grow, and we want our skin to grow, and so on, but we don't want to overgrow. And that's unfortunately what happens in cancer, is that cells that are meant to just grow to a certain point now kind of grow out of control, almost like weeds in your lawn. Think of them as there's good grass there, but then the weeds start to grow out of control. And that's really what cancer essentially is. What makes blood cancers unique is that those aren't just grass cells, or those aren't just, no disrespect to your lungs. Your lungs are important, but when you have a lung cancer, well, there's a piece of cancer there that we may have to try and remove or treat. But in blood cancers, it's a cancer of the very cells that are meant to protect you, like I showed you with the immune system. So it's kind of like the double whammy that unfortunately, not only do you have a cancer, then the very cells that are supposed to help you are now the ones that are starting to hurt you. So multiple myeloma is a cancer that starts in the bone marrow, and it starts from a group of cells that you're probably not familiar with, most of us wouldn't know, that are called plasma cells. And plasma cells are really important, even though you don't know, perhaps you don't know very much about plasma cells. We've all been talking about plasma cells for the last year. When everyone's been talking about COVID, and we've been talking about, oh, do I make antibodies against COVID? Oh, I'm going to get a vaccine so I can make antibodies against COVID or the flu or tetanus. That happens because your plasma cells make those antibodies. So they make these good antibodies that help you fight off infections. Unfortunately, those same cells that make antibodies that are usually good, in myeloma, now those cells become bad. And those cells now make bad antibodies. Sometimes we call them M proteins or monoclonal proteins. So instead of helping us, now they actually hurt us. And so these bad proteins can circulate in the patient's blood, and they can cause all sorts of damage. So who's at risk of multiple myeloma? Well, we have this year, unfortunately, probably about 33,000 new patients will be diagnosed with myeloma. But as I mentioned from the start, it's more common as we get older. It's twice as common in the African American population. It's a little bit more common in men than in women. We do see a little bit more myeloma in obesity. And as we're going to describe earlier, if someone has already had this diagnosis of MGUS or the pre-myeloma condition. The good news in general about myeloma, as I mentioned from the start, is that we're seeing improved survival in myeloma. We're seeing and I know you may not be familiar with looking at these curves, but what we want these curves is to be a nice horizontal line. We want fewer and fewer people to die of this disease every year. And as you can see, the lines are moving up, and we're just about ready to add another line to this curve in blue. In gray at the top is the general population that don't have myeloma. So even though we're improving in myeloma, there's still a gap there. There's still a disparity between those who do and do not have myeloma. So to recap, myeloma is a cancer of the plasma cells. Plasma cells normally make good antibodies. As you know, in medicine, we love to use words that patients don't understand. So instead of calling them antibodies, we call them immunoglobulins. So you may see that word. And we have different types of immunoglobulins. And so now in myeloma, these plasma cells make bad proteins or bad immunoglobulins. It accounts for about 2% of all myeloma patients. As I've mentioned, it's not a very common cancer, but as we're highlighting today, twice as common in the African American community. Now, I indicated this early on, but the diagnosis is tricky because we don't just normally do a blood test and look for those bad proteins in anyone's blood. There may be people listening today, there are people walking around today that have this bad protein in their blood, and they've never actually had it detected. So how do people present with myeloma? What symptoms do they have? Well, a third of patients have fatigue, and a little over half of patients have bone pain, typically in the back, but sometimes in other places. And this is because these bad proteins can attack the bone. People get fatigued because the bone marrow, the factory of your blood, is so busy making these bad proteins that they don't make the good cells. They don't make those trucks that I talked about, those red cells that give you oxygen and give you energy in life. And then lastly, to be more specific on that, those red cells, when they get low, we call that anemia. Those red cells together, we call them hemoglobin. You may have heard that word before, or someone says, I got a low red blood cell count, or my doc says my counts are low. This is typically the red cells. And in 3/4 of myeloma patients, they have red cells. So one of the important things in Empower Charlotte is to have people think if someone's red blood cell count is low, that this should be one of the considerations that potentially someone has multiple myeloma. And so one of the reasons why we would investigate with looking at those bad proteins in the blood to see if they're there. Now, this may look complicated, and I know that Manish is going to share with us more details in a moment, but this was just to remind us that myeloma is a spectrum, meaning we have people that have a little bit of bad protein in their blood, but they actually don't have true myeloma. It's okay to have a little bit of it. It's not actually hurting anything. And then there are people that have a lot of this protein, and it's clearly damaging their bones and potentially even their kidneys and their bone marrow, as I've described. And so trying to understand that has become really important, because as we all know, we want to catch cancer earlier before it becomes a greater problem. And that's clearly what we want to do. Because when myeloma damages the body, we classically call it the CRAB criteria. So you may have seen this phrase used before, CRAB. And CRAB stands for the calcium, or which is chemistry in our blood. This thing that we can test in the blood becomes too high. Renal or kidney damage, anemia, as I've described, as a low red blood cell count, or bone disease. And sometimes it's just a thinning of the bone, and sometimes it's actually fractures of the bone. And that's why it can cause so much pain. And so as we think about these CRAB features, we have to look for them really carefully, because when people have low blood counts, they get tired. When they have low white blood cell counts, I showed you that it was part of the immune system, they can get infections. And a lot of our patients, unfortunately, have a lot of infections before they get discovered to have multiple myeloma. When the bone is damaged, of course, it can cause a lot of pain. And it can actually, because the body is so busy making these bad cells, people can lose their appetite, they can lose weight. So a lot of people can get very sick with myeloma before they're diagnosed. And then, of course, there are some patients that have no symptoms at all. The myeloma is growing in the background and it's starting to damage their kidneys or damage their bones, but they don't feel anything yet. And those are people that we want to catch earlier before it causes even more damage. And so when we think of treating myeloma, this isn't a simple thing. I've already mentioned that it involves the kidneys and the bones and the blood. There's lots of different people that have to be involved with this. And when we think about how we're going to talk today a little bit about treatment, we have to put at the center the patient and what they prefer. Thankfully, we have options in myeloma that we've never had before. And so it's not just a question that I, as a doctor, come in, and we're going to hear so much more from Amy and Tiffany about this later. But, I'm not the doctor that comes in and says, you're going to take it and you're going to like it and you're going to ask for more. I mean, that's not the way we practice medicine. We share the options with patients. We look at their symptoms. As I say all the time, I don't treat myeloma. I treat people. And so people have to be looked as like people and not just a disease. And so we have almost innumerable number of drugs now. We have these 4 major classes of drugs that we call proteasome inhibitors, immunomodulatory drugs, monoclonal antibodies, and alkylators. And for some of you, this is old hat. For some of you, this is new information. And I know it's a lot to take in, which is why, as Kelly said, we're going to have replays of this and the slides available to you so you can review them if you wish. And of course, we're always available to you to explain more. But what's exciting to me in myeloma is we've had for many years these 4 major pillars, and now we're adding more treatments. We have new immune drugs. We have new drugs that you're going to hear about today called belantamab and selinexor. And then hopefully in the very near future, maybe within days to weeks, we'll be able to use what's called CAR T-cell therapy in myeloma that Pete is going to share with us in just a minute. But when we think about treating people, so in my last few minutes here, I'm going to share with you some thoughts around how we treat people with myeloma when they're first diagnosed. And then Dr. Voorhees is going to share with us a little bit more about what we do when, unfortunately, the disease comes back. Because as we're going to hear, sadly, this is a disease that we're not curing right now. We get it under control in almost all patients, but then at some point it comes back. And so we want to be able to be prepared for that. But part of the best strategy for patients is choosing the best treatment for them up front. And right now, we still basically split patients into 2 categories once they're first diagnosed, whether or not they're what we call eligible or ineligible for a transplant, or what's called an ASCT, an autologous stem cell transplant. And so that often makes the differentiation. And I won't go through all of the details of that, but it partly has to do with age, but it usually has to do with a lot of other things about how their general health is and the other conditions that they may or may not have, knowing that myeloma, as we mentioned, is more often diagnosed in older patients. So if patients are eligible for transplant, we go down a certain path. If patients are not eligible for transplant, we go down a different path. Although I must say, the paths are very similar these days in the drugs that we use to treat myeloma. The difference really is just in whether or not someone gets a transplant or not. And so we have these what are called treatment algorithms or suggestions of how we do it. For some of you, this is, again, brand new and it may be a lot to take in. But let me just share in brief that if we're not going to transplant, typically we're giving one of two triplets. And I go back to my notion about how triplets are so important in myeloma, using 3 drugs together. We typically give a triplet called VRD, or Velcade, Revlimid, and dexamethasone, sometimes also called bortezomib, lenalidomide, and dexamethasone. Or we give DRD, Daratumumab, Revlimid, and dexamethasone, sometimes called Darzalex. And so those are the 2 major options that we have, and based on patient factors, we make a decision. For people who are going to transplant right now, the standard is VRD and then going to transplant. Sometimes we go immediately to transplant, or sometimes we delay it. What I'm going to share with you in the final few minutes I have is how we're seeing new things that are influencing this treatment algorithm, so that if we do an Empower Charlotte workshop in a year from now, we might see this change in what we're going to be offering to patients. The notion of giving VRD is based in what was called the SWOG 777 or SO777 clinical trial that compared giving VRD to just RD, because for many years we were giving RD or Revlimid and dexamethasone. This was actually led by Dr. Dury, who's the chair of the IMF. And I won't go through a lot of detail, apart to show that you can see there highlighted in 41 months that there was a real improvement in people staying in remission when they got the triplet VRD versus just what we sometimes call the doublet of RD. And in fact, this has not only affected their time in remission, it's actually affected their overall survival. And so we're seeing survival rates improving in patients when we've been able to use this triplet. Similarly, a very similar design, we had one instead of VRD with Velcade. Now we're using Daratumumab. As I mentioned, these are the 2 options available to people that aren't going to transplants. And in a similar way, we see this movement in the curve that shows to us that when you get that triplet, that DRD, that people stay in remission for longer. It's still a little bit early to determine whether or not it affects overall survival, but we anticipate that to come. So those are 2 very good options for patients who are not going to transplant, either VRD or DRD. Now, for those who are going to transplant, there's 2 studies that I want to show you that before I wrap up that will help us understand how myeloma treatment is changing. And the first of them, and again, it looks kind of confusing here, but if you look in orange at the bottom, it's giving VRD, or sometimes we call it RVD. We switch the letters around, same thing. But what we're trying to see if we can make it better. So if VRD was better than RD, can we make VRD better by actually adding that Daratumumab to it? So from going from 2 drugs to 3, can we maybe actually make it better with 4 drugs? And this was just presented at our big hematology meeting in December, where we looked at what was called this GRIFFIN study, where patients were given this extra Daratumumab drug in addition to the VRD. And the short version was that people had better and deeper responses when they had Daratumumab added to their regimen. So it's still a little bit early to see how long they stay in remission, but one of the principles of myeloma is getting a deep response, because deep response means durable response. What I mean by deep is if in lung cancer someone has a tumor that's 10 centimeters long, we want to see it not just shrink to 9, right? We want to see it shrink to 7, 5, 2, 1. We want to see it go away entirely. In myeloma, we follow blood tests with those bad proteins in the blood, and similarly, we want to see the number come down. And we call it a response when it comes down by half, but we want it to come down even more than that. What you can see here in these purple color, for example, is people that have gotten pretty well 0, all the way down to 0, where they've almost entirely eliminated their bad protein in the blood. And so when we look at these different studies, for those of you who are familiar with these studies, we've looked at all sorts of ones. We're now seeing people get into complete remission and even to what we call MRD negativity, where we can't even detect the disease at rates that we've never seen before. So it's quite likely that in the near future, we're going to go from triplets to quadruplets adding this fourth drug. And the last study that I'm going to show to you today is a very interesting Italian study that some wondered, do we still have to do transplant in myeloma? And so this was a study that compared giving 12 months of drugs, in this case, carfilzomib, or what's sometimes called Kyprolis, carfilzomib, Revlimid, and dexamethasone, versus giving 8 months of that plus a transplant. And even though the depth of response, and you may or may not be familiar with looking at these kinds of tables, but let me just narrow it down to the blue numbers. Look at 58% and 54%. So in both of those groups, they got over half of their patients to undetectable levels of myeloma. But if you had a transplant, you stayed in remission longer. That what we call progression-free survival, how long people stay in remission. And so that was a very important point, that we still see that transplant has a role in multiple myeloma. For those of you who are particularly interested, there was a second part of this study where after people got that initial treatment, they either stayed on Revlimid maintenance or were given Revlimid maintenance plus carfilzomib or Kyprolis, and that actually also seemed to have a benefit as well. So it could be that even though right now we give Revlimid all the time in maintenance therapy, we might be giving more of that in the future. So my conclusions for frontline therapy is we're likely going to be moving towards quadruplets in the not so distant future. Number two, transplant still has a role in myeloma, even with all these new fancy schmancy drugs. It's still unclear if we need to give more treatment right after a transplant. We're trying to explore that a little bit more. In that GRIFFIN study, it looked like people got better responses when we gave them more drugs right after their transplant. So we're still exploring that. And there is a likelihood that before too long, we're going to give more than just Revlimid for maintenance therapy. So as I show you here pretty well, my second to last slide, this is almost like an alphabet soup here of all the drugs that we have. When I first started, when Pete and I started working together in myeloma, I'm sorry, Pete, but it was over 20 years ago, buddy, that we had maybe 2 or 3 drugs available to us in myeloma. And now we're in the teens of how many drugs that we have available. And I wouldn't be surprised if we have another 4 or 5 available just in this coming year. So it's an exciting time in myeloma. For some of you, you can quote all these drugs off your heads. For some of you, this looks like a different language. But let me put it this way, that we're very excited to see that we have more options. In red is what you see here, what we've been using for many years. In green, what we've just added. And in purple, what we will likely be able to add within the next 1 to 2 years. So it's really exciting to see this myeloma. And we hope that there will be even more opportunities before too long. So at this point, I'm going to turn it back to you, Kelly, and just thank you for giving us the opportunity. I know this was a lot of information, especially for some of you that may be new to myeloma, but we hope it's helpful in understanding how we think about this disease and what's the latest research in understanding how we treat it at diagnosis.